I've been asked to introduce my good friend, Dr. Rochelle Dicker. Dr. Dicker is the founding director of the University of California, San Francisco Center for Global Surgical Studies and the San Francisco Wraparound Project, which is one of the leading violence intervention projects in the country. Dr. Dicker provides oversight and mentorship for both of these programs and is also active in her research in Uganda. She's also currently the vice chair for critical care and the chief of surgical critical care and the associate chief of trauma and emergency general surgery at the University of California in Los Angeles. So really excited to have Dr. Dicker with us today. She's really an expert in violence intervention programs and has been a leader in that nationally. And she's going to talk to us a little bit about trauma-informed care. She has led the development of a trauma-informed care curriculum that we've been rolling out as a pilot project through the American College of Surgeons Committee on Trauma. And we'll share some of that experience as well. So I think she's virtual, so hopefully we will see her soon. Dr. Dicker.
Thank you so much, Dr. Balger. I appreciate the introduction very much. And I'm very sorry I can't be with you today, but I will try to impart some thoughts that I have about implementation of trauma-informed care into clinical practice guidelines. Can you all hear me okay?
We can hear you great, Dr. Dicker. I apologize. We are unable at the moment to see your face. You're going to be a voice in the clouds, but thank you for joining us.
No problem. And just let me know when you have the slides up, and I'll start talking about the first couple of slides in the meantime. So, I just want to say how much I really appreciate Center. The people of Center are phenomenal. And I also just want to thank Lacey Legrone. What an inspirational conference, and a different kind of conference that's so necessary. So I just want to congratulate all the folks that put this together. So with that, I'll talk to you a little bit about trauma-informed care. And I have to say, when Lacey first asked me about this, and if you would advance the slide and let me know if you see what you're seeing right now on the screen. Do you see the screen? Okay, because I'm not seeing I'm not seeing what you're seeing. So help me out here in that way. I really have to admit that I thought, well, this is going to be a little bit different. I'm not exactly sure how to go about it, because I think what we need to be doing here, and what I've heard already this morning from the phenomenal speakers, is that we have to teach how to teach the content, not the content itself. And so we need to basically pull apart and name the process. And for this particular talk, introducing the idea about how to bake in healing into our clinical practice guidelines, and how to be deliberate about the that lend themselves to trauma-informed care. Trauma-informed care isn't more, it's just different. Next slide, please. And if you're seeing that slide about mores and folkways, kind of scrub away the cobwebs of your Sociology 101 courses, and remember that folkways are more, they refer to unwritten and informal social rules and norms that are expected to be followed, whereas mores refer to unwritten, informal norms and rules that are considered offensive to violate. Now, you can go down the line and see what these are. And why am I talking about that here? Because I think really trauma-informed care is how we tweak a folkway or even a more in our trauma care. And again, it really is, I think of it as clinical practice guidelines being the bones and trauma-informed care being the flesh. Next slide, please. How do we then effectively teach trauma-informed care? And that concept can be a bit more nebulous than a typical clinical practice guideline, but hopefully with the next few minutes, I will get you to start thinking about the way that we don't think of it as separate and apart, but an essential component of our clinical practice guidelines. But it can be even more confusing for people with a first language that is not English to think about trauma-informed care. The words are just not as meaningful in certain ways. So we really got it in terms of humanistic care. And real life and participation are really vital to incorporate into adult learning. And Lacey started us off talking about adult learning, and I'm going to share a few other concepts with you in a moment about that, because it's so essential as we think about trauma-informed care incorporation. Next slide, please. As Eileen said, the American College of Surgeons Committee on Trauma has launched an effort in a trauma-informed course curriculum. And we have now piloted this curriculum at 23 trauma centers. Over 130 instructors have been trained and have then gone on and passed along to 1,200 people this concept and the curriculum of trauma-informed care. And the analysis is now occurring. As many of you know, also, trauma-informed care is going to be a chapter in the 11th edition of ATLS. It should be out probably in early 2025. But more important than it being a standalone chapter is that we really want to incorporate the values and the folkways of trauma-informed care into the entire book of ATLS. Next slide. So when we think about trauma-informed care, really, it's a part of everything that we do or don't do with our patients and with our colleagues. So think, for example, and this is the part where we really want to start thinking about how to be deliberate in the pieces that lend themselves to trauma-informed care. So chest tube placement, you have a clinical practice guideline, you have an algorithm, or the bones, if you will, of how to place a chest tube. If you start to put the flesh onto that clinical practice guidelines, onto those bones, that's trauma-informed care. What do I mean by that? Well, part of that clinical practice guidelines is using lidocaine to inject specifically into the pleura itself, because we know that that's rich in somatic sensory fibers. So we really encourage our learners to try to get that lidocaine into the pleura itself. And so if you think about and be deliberate about pain management in placing a chest tube doesn't have to be a painful experience to the patient. That's trauma-informed care. So pick apart each of your clinical practice guidelines as you implement them and put in a little nuanced note next to that particular part. Well, pain management, that's trauma-informed care. So think about that in every endeavor. And so I'll go through with you a story, because that's part of what is so important about adult learning. So here's the initial presentation of a real life story. It's a 20-year-old black man who suffers multiple gunshot wounds, and he arrives with EMS and the police. Blood pressure on arrival is a systolic of 75. He's lethargic but awake and handcuffed to the gurney. ATLS has started. A and B are seen as intact at that point, although his systolic is a little on the lower side, and his chest x-ray is negative. We see 3 torso bullet wounds. The initial resuscitation reveals that he's a transient responder with a base deficit of 12, and his FAST is positive, so he goes to the OR. Next slide, please. Also, what's happening in the trauma bay is as he rolls into the bay, someone says, "Oh, I bet this guy was just minding his own business." Now, this is happening during our clinical practice guideline of ATLS, and the algorithm took us to the OR. But this also is the reality of the patient. And when asked why he was handcuffed to the bed, he was billed as reportedly combative or, quote, probably up to no good. On the way up to the OR, a nurse quips, "Does his tattoo mean he's in a church choir?" Next slide, please. So in the OR and beyond, he requires massive transfusion, back to our clinical practice guidelines, and damage control laparotomy. And there's an injury to the iliac vein and artery, small bowel, large bowel, pelvis. 12 days later, after 3 more operations, he's awake and extubated. And on rounds, the chief resident asks him to remove the covers that are over his head. Patient doesn't remove the covers. So the chief resident pulls the covers down while saying to the team, "This guy is just so non-compliant." Next slide, please. This is that guy. This is Malik, and Malik entered our hospital-based violence intervention program and is now a social worker in the Bay Area. So what this all means is that the flesh of these clinical practice guidelines, again, is the trauma-informed care component of it. And there are ways at every moment of that story that I bet all of you can tell us how things could have gone better for Malik during that time. And frankly, how the care could have been delivered in a more satisfying way for the providers. Next slide, please. And there are lots of stories like that, and one of those will be a vignette in the trauma-informed care chapter for ATLS, but also it'll be woven through the chapters. And each of you has one of these stories from wherever your vantage point is, patient or provider. And what is your story? And I would encourage you to think about that and what you observed or what you did with our own implicit biases and how that could have gone differently for your patient and for the whole team. And this is the ACS DEI toolkit contribution that we made to defining trauma-informed care. It's a lot of words, and I put it up here on purpose and happy to share it with you. You can see it on the website for the American College of Surgeons. But what I wanted to emphasize here is that knowledge and information, passing that along is really critical, but the story I just told you probably resonates a little bit better than reading a slide. So for adult learners, it really is critical that we weave in these ideas of stories and real life experiences into the way we teach. And adult learning, and Lacey went over this a little bit, keep the lesson relevant, focus on learners' life experience, tell stories, break up the information. You just had a 10-15 minute break. Visualization of how to apply information, provide feedback, encourage discussion, be flexible, and make your material visually stimulating. And now I'm going to go through a little bit of the curriculum with the time that I have left and point out these different components of adult learning and how we're hopefully going to, for our 2.0 version of the curriculum, tweak them even more to be able to really have it resonate with our adult learners. Next slide, please. So this is the title slide for trauma-informed care for the American College of Surgeons. Next slide. The structure of the curriculum, and think about that adult learning aspect of it. It's lectures and didactics, and I'll go through a little of that with you. But again, I'm trying to instill on the teaching of how to teach instead of the teaching of the content. And it's setting the stage and laying the groundwork. That's really important, and expressing the fundamentals. The observation part and the practice part are really woven into the vignettes, like the one that I gave you about Malik. And then there's storytelling, and we have, as part of our curriculum, a lived experience expert from the community, because although you need a lot of fidelity, it's really important that that we also express this idea of hyper acute locality. So people's lived experience is going to be different in San Francisco than it is in Kansas City. And bringing in a lived experience expert and paying that person for their time is really important. And then there's the conversation, a discussion of our own vicarious and secondary trauma. And I'll talk a little bit more about that in a moment. And practicing the vignettes as is set up so well. And if you think about how ATLS is set up, it is a really prime marker of how to teach adults. So the goals and objectives, next slide, please. The goals and objectives of trauma-informed care is to understand the impact of social determinants and to understand trauma in sort of a broader sense, really, and the impact of ACEs and the manifestations thereof. And I would encourage you to hear any lectures from Stephanie Bonney, who I know is virtual on this, who gives phenomenal lectures on ACEs or adult adverse childhood experiences. And then identify and define the PEs, the 4 Rs, and the 6 Ps of trauma, and then understand the concept of Martin Luther King's beloved community and the characteristics of what it looks like to be trauma-informed, and then how to render appropriate support, of course, is the most essential piece of that. I'm not going through all that with you. It's just important for adult learning to really lay out those goals and objectives and to be able to implement a way of actually getting them across to your learners. Trauma itself is a very difficult or unpleasant experience that causes someone to have mental and emotional struggles over time. So trauma isn't just about that injury. The injury part is the bones, but the flesh of the person, that's trauma in the broader sense. And it's important to think about that in a more three-dimensional way than we did with just the scaffolding of what we learned in our trauma fellowships. And then social determinants of health, those are conditions in the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So these all are really important in trauma-informed care curriculum. We want to set the space. So trauma is a lack of predictability, a loss of control, but our role really is to create an environment in the health setting that gives a sense of all of these and contrast potential negative cognitions. So it's not just the initial ATLS protocol, but it's down the line too. And I loved what Mr. Nguyen brought up about music, about culture, about religion. That's so important and doesn't have to be mutually exclusive from the hospital experience or beyond. In fact, it shouldn't be mutually exclusive. It really is the flesh on our clinical practice guidelines. The 3 E's of trauma are the event, the experience, and the effects. And these are very much conducive to giving stories and real life experiences. And you'll hear that in the conversations that occur with the lived experience expert. And then becoming trauma-informed care. And if you jump to the slide with the 4 R's, that means that we realize the widespread nature of trauma. We respond by fully integrating trauma into practices. We recognize the signs and symptoms of trauma and resist the act of re-traumatizing our patients by making explicit and implicit comments or actions. And so all of these concepts of the 4 R's are really conducive to us being proactive and deliberate in how we think about delivering trauma-informed care. And trauma-informed care isn't more, the pushback sometimes that I'll hear is we don't have time to put more into this. But if you think about it and you practice trauma-informed care and you connect with your patient, it actually creates an environment where things are much more efficient, not just much more humanistic. Principles of trauma-informed care include safety, trustworthiness, and transparency, and peer support, in addition to collaboration and mutuality, empowerment and choice, and an awareness. So all of these are brought into trauma-informed care. I'll skip this slide for the sake of time. So then think about those adult learning experiences. And so the changing experience looks like this. It promotes autonomy, decreases helplessness, improves communication, values the individual, promotes validation. And then for the caregiver, it decreases frustration, it improves empathic communication, it raises awareness of biases, improves job satisfaction, and reduces bias. So specifically in our curriculum, those adult learning concepts include these vignettes where each of the 23 sites across the country have given us examples of their own scenarios for trauma-informed care and non-trauma-informed care. And so we've shared those widely. And one of those will be incorporated into ATLS, perhaps more as we start to roll out trauma-informed care in each of the chapters of ATLS. And then, as I mentioned, there's this session that is really extraordinary, and we have great feedback on this, that's led by a member of the community impacted by trauma, implicit bias, and structural racism. So this is a conversation with a lived experience expert, and a lot of storytelling occurs during that. And the discussion of vicarious and secondary trauma in providers is led by a mental health professional. So this is the part that's the conversation that occurs also during the curriculum, and this has been quite popular across the country. And then next slide. So trauma-informed care in ATLS creates communication and connection at every juncture of it, particularly the secondary and tertiary surveys. Practicing trauma-informed care is very conducive, but at each stage, and as I mentioned, even placing a chest tube, every element, just think deliberately about what part of that clinical practice guideline is an implementation of trauma-informed care. It absolutely goes into research, and we're analyzing what we're doing right now with our course. And we really have to think about it in terms of humility, humanity, and relevance. So if we're really an accomplice, not just an ally in community-based participatory research, the community has a significant prominence. So the end user or the patient really is absolutely essential in putting together research projects from inception to outcome. And finally, so for this design for implementation pre-conference survey, think about all the different ways: open access, comprehensive and equitable communication, regular review and updates. These are all things that we're doing with the curriculum. And then integrating options for local adaptations. That's where we talk to our lived experience experts in our specific communities. We have a platform for feedback through our Qualtrics survey, and ease at the bedside. That's the whole broad idea of trauma-informed care, is ease at the bedside for everybody involved. And then just a couple of our comments for our course. I thought that this was a great informative course. Our team is more aware of biases, but we can always improve. The things mentioned in the class brought up ways in which bias may affect us and our patients. So we have a lot of those comments like that. And then I'll just close with this concept again of how with trauma-informed care, they actually are really conducive to dovetailing very well into the implementation of our clinical practice guidelines if we're particularly deliberate about the way we put the flesh on the bones. And it probably is a tweak of both mores and folkways. And you can see that change as you start to implement trauma-informed care in your particular community. So with that, I'll close. Again, I apologize for not being with you in person, and I want to congratulate all of the folks who put this great conference together. Thank you.
Thank you, Dr. Dicker. And we're going to try to get your face up on the screen, but I think we have time for one question. If anyone has a question for Dr. Dicker. Dr. Dorlack.
Hey, Rochelle, Ward Dorlack here. I have a question. One of the patient representatives that spoke earlier in the morning, Mr. Arnold, spoke about what we say isn't always what patients hear. And I'm wondering, what is your fix for that? Because I think all of us have experienced this.
Yeah, thanks for that question, Warren. I definitely have experienced that. And I think it is really important to become an accomplice, not just an ally. And what I mean by that is really understanding the community that we serve. And so, for example, like what Mr. Nguyen said earlier about his mom, that she wanted to be called by her last name. These are things of understanding the culture of the people we're treating. Do they want to listen to hip hop, or do they want to listen to new wave music? These are important aspects of not just caring for our patients, but healing our patients. So the more we can get to know and have things like boards, for example, really advisory boards from our community to help us to understand the communities we serve, I think are really important. So I think that has improved. All of us have biases, but I think that really improves the way we care for our patients and the way and that includes how we talk to our patients.